Hi, everyone. Welcome to our Sepsis Denial Appeal Workshop. This is the first of 3 workshops that PayerWatch and AHDAM are presenting to our attendees. Today, our speakers are going to be Dr. Paul Ossman from UNC Health, Dr. Kendall Smith from PayerWatch, and me. I'm your host and presenter, Denise Wilson. I'm with PayerWatch and with AHDAM. Okay, so we've got a lot to get through today. Our sponsors for today's webinar are PayerWatch. PayerWatch is the nation's leading provider of payer denial, audit, and appeal solutions. Our Veracity platform powers your clinical revenue cycle with the most comprehensive denial and audit solutions. And also the Association for Healthcare Denial and Appeal Management. We support professionals working in the field of denial and appeal management through education and collaboration. If you haven't joined as a member yet, please make sure you check us out. It's $125 a year for annual membership at www.ahdam.org. Okay, so today's webinar, I've got a call-in toll number for you and an access code for those who are not using your computer speakers. I'd like to put that up there in case people decide they want to call in. Today, we're going to discuss the ongoing dichotomy of Sepsis 2 and Sepsis 3 and how do you support arguing for SEP 2 criteria when a provider is using SEP 3. So all 3 of our webinars are going to be kind of discussing different avenues of working with SEP 2 and SEP 3.
Denise,
Dr. Paul Ossman?
Denise, the slides are not moving forward.
They're not moving? I'm so sorry. Thank you for letting me know that. I have them paused. Okay. Now, are the slides moving?
They are, but the slide view and not the, so you want to click from beginning?
I'm sorry?
You're showing the,
present
the wrong,
view.
yeah.
Okay.
Did you go to the top left from beginning? Or
I think I'm just showing the Did that change it?
no, try view. Top right.
That's the right view. So put that back and just click on the first slide. Yeah, there you go. From beginning. Try that. Didn't seem to do anything. So that's okay. That's fine.
Okay, let's do this.
There you go.
Okay, now it's working?
Yes, there you go.
Okay. Gosh, so sorry, you guys. I mean, I do these all the time. That's really unusual for me not to have my slides straightened out. All right, thanks for your patience. All right, so back to today's webinar. Dr. Ossman is going to discuss current and future state of addressing this dichotomy at UNC Health, and then Dr. Kendall Smith and I are going to provide insight on appealing a denied sepsis diagnosis when the provider uses SEP 2, but the payer uses SEP 3. All right, so the number 2 and number 3 workshops are up and ready for registration. You do have to register for each webinar separately. It's one registration page, but there is a drop down that you select to register for workshop 2, and then go back to the registration page, use the drop down to register for workshop number 3. So our next one is next Thursday, September 22nd at 1 p.m. And we're going to have Dr. Agvanian from Adventist Health, who's going to, is a physician advisor there, and he's going to speak about the experience at his organization. And then Christy Drum and Garnett McLaughlin are coding and clinical validation experts, and they're going to be on that webinar as well to talk about those types of denials and appeals. Number 3 is going to be on a Wednesday, September 28th, again at 1 p.m., talking about sepsis current state, and our guest speaker there is going to be Dr. Hesham Hassabala from Sound Physicians. Dr. Kendall Smith and myself will be on that one as well. So make sure you register for those if you're not registered already. You do have to register for each one separately. Okay, and so the reason behind doing this webinar today is that September is Sepsis Awareness Month. So in recognition of that, we came together as PayerWatch and AHDAM to present this series of Sepsis Denial and Appeal workshops. Sepsis is the leading cause of death in the U.S. hospitals, and the lack of the definition and treatment consensus between payers and providers, commercial insurers, is infuriating and sometimes dangerous. We encourage you to support the Sepsis Alliance, and you can learn more about that at www.sepsis.org. At the end of the presentation, I'm also going to talk a little bit about some state rules and regulations and things that are going on with sepsis awareness in your state. Okay, I'm Denise Wilson. I'm Senior Vice President at PayerWatch and Appeal Masters, President of the Association for Healthcare Denial and Appeal Management, and I've been in healthcare my entire career and last 17 years specifically in managing denials and appeals. Dr. Kendall Smith is a Senior Fellow in Hospital Medicine, currently acts as Chief Physician Advisor for PayerWatch. He's a leading appeal educator and appeal services, He's a leading educator as well for hospitals and health systems. He's been deeply involved in denial and appeal management throughout his career, and he serves as a physician advisor for clinical resource management. He's also an HEMA ICD, CM, PCS approved trainer and ambassador. And our special guest today, Dr. Paul Ossman. He's a practicing academic hospitalist at UNC Chapel Hill. He's been involved with UNC since medical school in 2001. Where he completed his residency. He currently serves as lead physician advisor for CDI at the medical center, and as such, he focuses on DRG optimization, insurance denials, and the role that CDI plays in expected mortality reporting. His work's been recognized with a Quality and Safety Award and special recognition for institutional spread and sustainability in recognition of the Project Mortality Reduction Program. He's a member of the American College of Physician Advisors, been a speaker at their national conference, IMPAC, and a presenter to the Vizient Collaborative, and interviewed for the report on Medicare compliance. And just a good guy to listen to. So we're going to start off with a poll, and when I open up this poll, you'll be able to click on 3 responses to this particular question. How do you define sepsis in your practice? I'm going to open up the poll and leave it open for about a minute, and we invite you to select one response out of the 3, and then we will show the results to all of you and start our discussion there. So number 1 is sepsis is a spectrum from non-severe sepsis through severe sepsis to septic shock. Number 2 is that some providers still use SEP2, but more and more providers are moving to SEP3. And then number 3 is all sepsis is severe and severe sepsis is redundant. So let me open our poll. All right, people are answering already. Very good. Okay, so number 1 is sepsis is a spectrum from non-severe sepsis through severe sepsis to septic shock. Answer number 2, some providers still use sepsis 2, but more and more are moving to sepsis 3. And number 3 is all sepsis is severe and severe sepsis is redundant. Good, we're getting good response rate. About 70% of you have entered a vote so far. We'll close it out in about 10 more seconds, and then I'll be able to display that to everyone.
Paul, and thinking while people are answering this, I think we missed a fourth a possible answer, which is all of the above.
You know, when we did this at one of our smaller meetings, someone asked, can we choose more than one? Which I think just shows you know, the issues here, and I think our quick poll shows it too. If I always worry when I ask this question that we'll get 90% of folks agree, and then we can just end our session. But you know, we've got about 50%, a little over 50% showing that there is still a kind of acceptance of that SEP2, of that SIRS plus infection, that idea that sepsis can occur without organ dysfunction. But within this group, and I don't think that's too surprising, being that you know, we have so many folks that have thought so much about sepsis, is recognizing that more and more people are moving to sepsis 3. And then the 20%, which are usually the loudest in our query responses when we used to query for non-severe sepsis, is all sepsis is severe and sepsis is redundant. So that the 20% of you, I think, I hope to have some answers for you as we move forward.
Okay, Dr. Ossman, I think you have control of the slides, so you can go ahead and get started telling us about your experience.
On my screen, I unfortunately only have the quick poll.
Okay, let me see if let me close that out.
There we go.
Okay.
All right, excellent. So there we go. Well, thank you for this invitation, and Denise, thanks for the invitation. But I think what we saw with our poll here, with our 500 attendees, is a bit of a microcosm of what we were seeing at UNC's Medical Center. We've got a 800 bed facility. We're serving more than 37 people every year. We employ over 1,000 medical staff and training over 700 resident physicians in a given year. Our system, of course, is bigger than what our medical center is in Chapel Hill proper. We have 16 hospitals, 20 hospital campuses, and about 500 clinics statewide. And we were finding that over the last several years, the agreement amongst our staff and physicians and sepsis educators has really shifted to favor more of a sepsis 3 perspective. And a lot of that is the issues with our SIRS plus infection criteria, the issue with sepsis 2, and many of these are very clinical issues. The fact that SIRS sometimes reflects an appropriate host response to infection. The idea that non-infective SIRS can coexist with an infection. The white count certainly is a very non-specific indicator for a systemic inflammatory response. The fact that sepsis is dynamic. We can have various criteria being present initially, and that many times SIRS itself fails to promote an understanding of the underlying problem or disease process. And I can remember as an intern, at that point, I think our clinical documentation book was about 8 pages long. And the advice that I was given was SIRS plus infection, you write down sepsis. And that was simple. It didn't really capture the problem, but it was simple. We also have found that many hypotensive patients don't necessarily have shock. But what we have found is that this is very resource intensive. Our sepsis patients are very costly. We get reimbursed appropriately, but that also makes this definition and this diagnosis highly audited. And I think that's the one area that sepsis 2 is superior over sepsis 3, is that it is easier to handle. And in a documentation standpoint, especially with CMS recognizing non-severe sepsis and sepsis, many times this can be a more favorable diagnosis. When we get to sepsis 3, however, many of our problems of sepsis 3 are in our documentation. They're in this paradox that if you agree with sepsis 3, you have this OCG guideline that basically has a disease that doesn't exist. We have non-severe sepsis, moving to severe sepsis, moving to septic shock. And according to Sepsis 3, non-severe sepsis doesn't exist. We also have difficulties when we adhere to Sepsis 3. We lose some of these A419 non-severe sepsis codes. That's going to affect our reimbursement. That's going to affect our quality analysis. It's also going to basically change the way that we're seen by regulatory agencies. I think that when we moved to following our clinicians' use of Sepsis 3, we certainly planned for this disruption. We knew going into it that we were going to leave some reimbursement on the table, and that to a certain degree, some of our quality analysis metrics would be affected. But what we're left with is a really clinical definition. And while that favors our clinicians, it further leads to ambiguity. And in future workshops, I think that's going to be addressed more than it will be here. But this idea that insurers are using this very ambiguous clinical definition and co-opting this SOFA criteria as a definition, which it was never meant to be. We'll talk a little bit about that today, but you'll hear more about that in future workshops. So what UNC's experience has been is to listen to our stakeholders, listen to our clinicians, and listen to our sepsis champions. Our sepsis champions at UNC have been teaching all sepsis is severe. They have been teaching this idea that sepsis is a life-threatening organ dysfunction due to a dysregulated host response to infection for years. It's very difficult to have clinical documentation not mirror what our physicians are using. Also looking at the writing on the wall, more and more of our denials were coming from those cases that were only supported under Sepsis 2, where we had cases where we had non-severe sepsis or sepsis without organ dysfunction. So by allowing our clinicians to lead the way, we're not having the tail wag the dog. I don't think UNC is unique in the sense that our physicians do not have a love for queries. And it's super inconsistent for queries to follow a definition that is contrary to the very definitions that are being taught to our residents, that are being taught to our providers from our sepsis champions. So listening to these groups has been really important in our process. What that means is in CDI, we were faced with a choice. And what we decided to do was to validate under both Sepsis 2 and 3. As the poll here showed, I think you all are a little bit different than the majority of providers at our institution, in that over half of you recognize this continuum. But UNC certainly has some physicians who still recognize sepsis as a continuum, who still recognize non-severe sepsis and are documenting in a way that is consistent with Sepsis 2. If that patient has SIRS plus infection and that clinician writes the word sepsis, we are still clinically validating that diagnosis. We know that we'll likely get an insurance denial down the road, but we are clinically validating that A41.9 diagnosis under Sepsis 2. Certainly, if a clinician writes sepsis and they have a clinical picture that supports Sepsis 3, they have that clinical picture of a life-threatening organ dysfunction, we're going to clinically validate that A41.9. We're also going to look to try to support our R65.2. Additionally, we're clinically validating that severe sepsis guideline under both Sepsis 2 and Sepsis 3. So however a provider supports that severe sepsis diagnosis, as long as they're the one who's writing down severe sepsis, we're going to clinically validate that under both Sepsis 2 or Sepsis 3 support. The big thing that's different probably from our organization than others is that we are in line to some of our area hospitals that are within our state, but not all. And that is that we are only querying for a misdiagnosis under sepsis 3. So if we see that patient without the magic words of sepsis, we see that they have sepsis 2 criteria, but we do not see organ dysfunction, we're not going to be sending that query to try to find A41.9. What we will be doing is sending that query if we see support for sepsis with organ dysfunction, but we're not sending queries to try to find and get that diagnosis for non-severe sepsis. That certainly has decreased our queries, and decreasing queries keeps us consistent with our ongoing sepsis education. It also, just reduces that query fatigue from our providers. It's reducing the workload of downstream denials. It's also reducing the possible inflation of our sepsis bundle non-adherence. For example, that patient who may qualify for non-severe sepsis, who is treated appropriately with fluids and antibiotics, but not to the level that our sepsis bundle would want us in compliance. Looking after the fact, we send a query to a physician and they may choose non-severe sepsis. We may very well be outside of our sepsis bundle compliance in that instant. But these decreased queries certainly have decreased our non-severe sepsis capture. That means we're missing out on revenue capture. Our DRGs are not fully optimized as they would be if we sent those queries for our A41.9. We also are seeing an increased mortality index under our Vizient mortality index. We're seeing that our not only is our mortality index slightly above 1 for our sepsis population, that mortality index is significantly higher than the mortality index that we've worked to get our overall population beneath. In balancing this kind of benefit risk, what we've also looked at is just, what would we be gaining, by sending these queries for sepsis 2, is that we would spend quite amount of resources, we'd be increasing query fatigue, and we would generally be getting negative responses from our docs since they are following more of a sepsis 3 mindset. But for those few cases that we may capture with all of these queries, we face 3 insurer denial letters and a peer-to-peer only to lose in the end. So, thinking about it pragmatically, but also thinking about it in just the sense of really trying to value our physicians at our institution and mirroring the practice that's going on. I think, where we continue to disagree with insurers, however, is organ dysfunction. You would think that if we're using more of a sepsis 3 approach, our problems with insurers and peer-to-peers would go down. But what we've really looked at is that this is a clinical definition, that sepsis with organ dysfunction is not a SOFA score. This SOFA score is a proxy for organ dysfunction that was used by the authors of the JAMA article, and that this proxy of organ dysfunction, the survival score on ICU patients does not apply to the vast majority of our patients. I think insurers have co-opted this SOFA score because it's easy. I think they've co-opted the score because it is highly specific and basically excludes many of the patients that truly have sepsis, and we're not getting reimbursed appropriately for those patients that may not have that SOFA score, but clearly have the clinical definition of a life-threatening organ dysfunction caused by localized infection. The advice that we've given our clinical documentation specialists and our coders is to look for how that patient is treated. Are they getting treatment that is consistent with a patient with sepsis? Meaning, is this different than a patient who would be getting treatment for a localized infection alone? we're looking for things like early goal-directed therapy, increased monitoring, increased evaluation, longer length of stay, expanded antibiotics, increased fluids, all of those things that are typical of the care of a septic patient and not consistent with a patient with solely pneumonia. And as we said before, when a provider is documenting sepsis, but we're not seeing sepsis with organ dysfunction, we are querying to capture that R code for severe sepsis. What's interesting is in some of the peer-to-peers, I've talked with some of the docs on these peer-to-peer calls, and they're willing to accept that sepsis alone should trigger a and R code. They're willing to accept that sepsis as written means severe sepsis, but they've done so on those calls where we're arguing over sepsis and not when we're arguing severe sepsis. So I don't know if they would back that up whenever it came to it. But also by looking for those R codes, what they're doing is it further gives us backup for this patient has severe sepsis, which certainly meets the insurer's definition. But also it's going to more accurately reflect our patient population. Lastly, severe sepsis, as a lot of you know, is an exclusion criteria for some of the CMS mortality buckets, meaning those patients with pneumonia. If they have severe sepsis or sepsis with organ dysfunction, they're excluded from that numerator. So capturing those R codes for the work that we're doing remains very important. When it comes time to validate with, after our clinical validation, when it comes time for a peer-to-peer, sepsis is one of our three main diagnoses, as I'm sure most of you will share: sepsis, acute respiratory failure, and severe malnutrition. And certainly what we're finding is that some of our patients that don't necessarily have a neat and tidy SOFA score are getting into the peer-to-peer range. We're going through our 3 letters to our insurers, and then we're getting to these peer-to-peers. And a lot of these patients are folks that maybe have a SOFA score of 1, but they're clearly in acute they clearly have acute kidney injury. Their baseline creatinine may be 0.08, and it just so happens that their creatinine peaked at 1.9, which gives them a SOFA score of 1. If they had gotten that extra 0.1 of creatinine, they would get their 2 points. And it's those patients that are right on the edge that we appeal most vigorously. And again, showing that this is a patient who meets that clinical diagnosis of a patient with life-threatening organ dysfunction. We look at things other than the SOFA score as well. We're looking at those patients where a troponin bump actually becomes demand ischemia, or as I'm liking to think of it more as acute myocardial injury. But whatever word that provider is using, that organ dysfunction is evidenced by that rise and fall of troponin. Looking at those organ failures that may not, because of the way the SOFA score trends, you just don't get your 2 points. We're still validating those, and we're still vigorously appealing those cases. And we're doing our letters of appeal and then taking them all the way to the peer-to-peer, and in many cases appealing to the medical director. In this work, really knowing where to focus our efforts is important. We ask our physician advisors to review all of our insurance denial cases. And I think by being more selective in our sepsis definition, favoring more of a type 3, sepsis 3 definition, we're having less appeals. So we're able to keep up with that oncoming rush, but knowing that for our physician advisors, this is not their favorite job. This is probably the least favorite thing that any of us do. It is also the thing that's hardest to show a return on investment. For any given insurance denial, we're going to have multiple physician advisors involved on the appeal process. We try to get a different physician advisor to review any one case at each different level, so that by the time it goes to a peer-to-peer, we have more than one physician advisor who's reviewed the case. I think that leads to an opportunity for kind of cross-training. We get to see each other's work. We get to make sure that we're being consistent with one another. But more than that, some PAs may uncover something that was missed by another. We also have, I believe, a much stronger case for our peer-to-peer, in that it's gone through multiple lives. But that work, even if we do get a successful, even if we have a successful appeal, that successful appeal has taken place over the course of months to a year, and attributing individual effort to that case becomes very difficult. And it's much easier to have that instant gratification as a physician advisor when you see a neurosurgical case and you find cerebral edema, when you have that GI case who's been here for 20 days with quite a highly reimbursed DRG, and you find severe malnutrition, which is the only MCC. Those kinds of cases really drive our return on investment. So it's hard to get our PAs excited about these insurance denials. We want to make them count. And where our efforts right now are going to, as a system, is we're really trying to track appeal letter success by payer, so that we can better prepare for our peer-to-peer, and we can also know when we're fighting a losing battle from the beginning. Additionally, we're trying to find if those letters that are universally escalated to a peer-to-peer, meaning each letter that we send is greeted with that same generic letter that we get the first time around. We're trying to spend less time on the letter writing and more time on that peer-to-peer, and also trying to establish that peer-to-peer relationship. And I think by being consistent from our group, especially with those organizations that have higher rates of denial, we're getting to know those physicians that run these peer-to-peers, and trying to find some type of kind of where we can agree to disagree. We have difficulty right now tracking the success rate just because of the way that these are managed and the different departments that they cross, from our revenue cycle through to our quality and training. But tracking the success rate of our Sepsis 2 versus our Sepsis 3 cases, tracking the success rate of those cases that clearly have a SOFA score of 2 versus those cases that were arguing for organ dysfunction without a SOFA score. And then also in appealing to the medical director, that takes quite a bit of additional effort on our part following the peer-to-peer. So just trying to track the success rate of those appeals to the medical directors as well. They're all ongoing projects that we're involved with. And next steps certainly are contracting, and I'm excited to hear more from Dr. Smith and Denise about how we're going to be working, advice about contracting. Certainly most of our contracts are through necessity and our utilization management team, but there are contracts that we have with these insurers, and certainly trying to carve in some of these most challenged diagnoses like sepsis, malnutrition, and encephalopathy. Can we come up with a shared definition? The fact that we haven't up till now probably shows that we're certainly on two opposite ends of the spectrum, but I think it would be mutually beneficial to find some kind of agreed upon definitions for contracting with these providers. And it would certainly resolve some of this back and forth.
Right, and so we did talk about this a little bit when we were preparing for this webinar today with Dr. Ossman about contracting. So I would be interested to know, we would all be interested to know really, if that is something that you have attempted at your organization, or have you attempted it and been successful in contracting it? Because my concern is not boxing yourself into a corner, like, we feel we are when we have contracts with payers who say we use interqual or Milliman for the inpatient status. Can you come to what you've described as a mutually acceptable definition for both sides? And if you've done work in that way or been successful now, I'd love to hear about it. You can send me an email personally at denise@ahdam.org and let me hear your story. So denise@ahdam.org. I'd like to hear whether that's been successful for you.
Absolutely, and getting data before going into those contracting talks will be essential, as well, as far as knowing, despite our very best efforts, what's going to get denied every time. At least gives us a good starting point for our kind of best non-negotiated option going into some of these talks. It's important.
The devil's advocate position, Paul, I think there is certainly a need to have these things contractually defined. We do have some concerns that the locking in a definition contractually does remove some of those cases where there's clinical ambiguity, where physician documentation of a patient that's outside that definition would capture the diagnosis. So it is a two-edged sword, but it certainly would cut down significantly on queries and the number of appeals that we're seeing with these three particular diagnoses, is to have some mutual understanding. The other concern, or the other thing to watch out for, is contracting takes a long time, and if you lock in a specific agreed to set of criteria for malnutrition, say, and a paper comes out a year from now that the hospital wants to embrace, it may be 4 or 5 years before you go back to recontracting. You're stuck with the old definition in that period of time. So there are some loopholes to think about and some caveats if you're going to go that route. I think most significantly is what's hot today and what defines things like sepsis today and malnutrition today may disappear 12 or 24 months from now with the Sentinel paper, and you may be stuck with the current definition for 5 years. So Denise and Paul, turn it back to you.
No, all good points, and again, probably reasons that we don't have those contractual definitions right now, but still something that we're thinking about. I want to save some time for questions, and I know Denise has a few extra things to add. So I'll just end with just the takeaway message, which I hope has been obvious, and that is that despite all of this back and forth of SIRS and SOFA, that sepsis is this clinical definition. And regardless of whether you're using Sepsis 2 or Sepsis 3, communication with your sepsis educators, with your clinicians, and with your champions is key, or you're very likely kind of falling all over yourselves trying to enforce a definition that your documentation folks are using that your clinicians are not. And then certainly, in looking for validation of sepsis beyond some of these scores, is just escalation from the standard of care for that underlying infection. And then what UNC is currently doing is trying to monitor our efforts and results so that we can better address some of these challenges moving forward.
All right, very good. And I'm sure our audience really appreciates hearing. Everyone wants to know, how are we doing? Are we kind of doing what everyone else is doing? Are there some ideas that we could implement in our own organizations? And we know this is, this is like, based on the number of folks who signed up for this webinar, just confirms that this is like one of our number one issues that we're all dealing with. Number two, this is also CDI week. So I want to say happy CDI week to all of our CDS attendees who are listening today. Also, ACTIS did publish their annual survey just recently, and it shows where they've had a 10% increase in CDS who are actually actively working in the appeals area. And also they listed, as you did, Dr. Ossman, the top 3 sepsis by far is outnumbering all the other diagnoses that are being challenged. So it's sepsis, respiratory failure, malnutrition are the top three. So let's talk about appeals a little bit. So just to give you some tips on what we do at PayerWatch in the written appeal back to the payer, making sure that you're citing in your appeal documentation the excerpts from the medical record pertaining to that diagnosis, the elevated temperature, leukocytosis, hypoxia, confirmation by infectious disease specialist, noting whether anti-infectives were used prior to admission because that can blunt the response to an infectious agent. Also looking at things like, are they on beta blockers, which can blunt their response to infection by, blunting their heart rate response. Things like that you want to be aware of as well that could cause a blunted response to infection. Looking at the vital signs at the time of presentation.
Oh, sorry, Denise, I was going to jump in and add that
Sure.
Sometimes subjective language, if we get outside objective criteria, things like ill appearing or toxic go a long way in supporting both peer-to-peers with Sepsis-3, for example, Paul, and if we're going to argue SIRS plus infection in terms of a Sepsis denial. So, encouraging physicians to write what they're seeing in front of them and capture that in colorful language, I've found often goes a long way on appeal or a peer-to-peer discussion where you have a patient that's toxic looking or mottled or something that doesn't fit into a box.
Right. Good point. And since we are, we're focusing on how do I appeal a SIRS plus infection when that was used by the physician and the payer wants Sepsis-3. So, so this is kind of guiding you through how to support that SIRS plus infection. Of course, a lot of that is based on their vital signs, their temperature, the tachycardia, and the tachypnea. So making sure that that is documented in your appeal. So one of the things that we do at PayerWatch is we will have tables built into our appeal letter template for sepsis and include those the body temperature, the heart rate, and the respiratory rate that are representative of sepsis. So we know for SIRS plus infection, we're looking for a heart rate greater than 90. So it's not, that's, technically not tachycardia. We usually think of tachycardia as 100 or greater. So you want to put your reference range for what's going to support the SIRS plus infection. So that you can document where is the temperature, the heart rate, the respiratory rate, what page is that documented on in the record, what is the recorded body temperature, heart rate, respiratory rate, and what date were those recorded. And then
I find
going
it's also
on
useful when you're writing that appeal for Sepsis-2 is to talk about despite analgesia, despite adequate fluid resuscitation. So when you see these values that are abnormal, showing that they are persistent over time and despite appropriate analgesia and fluids, we've had a lot more success on that route as well. Sorry to interrupt, but just a really important part of our process.
Yeah, Paul and Denise, I would add to that the impact of medications on vitals. So, in a patient who's hypertensive, the fact that their blood pressure is 110 and they're normally walking around at 180, or they're on verapamil or low pressor, and they've got a heart rate of 95 or 100, they're borderline tachycardic, that bringing forward the hemodynamic impact of medications as a side effect or inability to fill that box and noting that it would otherwise probably be much more significant is imperative during those peer-to-peer discussions and in completing these tables where you may not get all the way there. You may be close, but you want to push it over.
Right. So, obviously when you're writing your appeal, you're going to have narrative as well. And so the points that our doctors have pointed out are good things to include in your narrative, not just using, a table of boxes like this. But one thing I like about using a table like this or having it built into your letter is if you're not writing these every day, day in and day out, it's just, again, it's another reminder, and it kind of pulls it out, puts it in front of the payer of that. what is required for a diagnosis if you're using the SIRS plus infection. So here's a couple of statements you can use as well that we use at PayerWatch in our appeal arguments, is that there is not consensus in the medical community as to what constitutes sepsis, and Dr. Ossman just talked about all of that little conundrum or dichotomy. And we say, the payer in our appeal will say, well, the payer is referencing material that comes from SEP3, and that's only one possible piece of information that physicians may consider or may decide not to consider when they are evaluating and treating their patients, and physicians are not bound by one group's opinion as to what constitutes a certain diagnosis. So the SEP3 and even the SEP2 definitions were created by a group of experts' opinions. That's really what it is. It's a group of experts' opinions. So it's not as if it is, there's not like a magic bullet, a blood test, you know, or something that's going to say, yes, you have sepsis, or no, you don't have sepsis. And that's what kind of puts us in this situation of, you know, how do we define it, and define it in a way that it's making sure that the treatment of our patients is safe, effective, and timely, and that we're also within compliance for coding and clinical validation guidelines, and also getting appropriately reimbursed. Also, the third international consensus definition for sepsis clearly states that neither Q-SOFA nor SOFA is intended to be a standalone definition of sepsis, and Dr. Ossman, I think you covered that very well. All right, and then one more sentence that you can consider using in your appeals is to be sure the payer knows that there was consistent physician documentation in the medical record establishing the clinical evidence by which sepsis was diagnosed and treated, and severity of the conditions required continuous treatment, evaluation, and monitoring with abnormal clinical values attributed to sepsis by the physicians caring for the patient. And then you can go on and describe what those abnormal clinical values were and where in the record did the physician attribute those to sepsis. Seems like I haven't gone on that.
Surviving sepsis is also completely silent about how to define organ dysfunction, and that's both across CHEST, the Society of Critical Care Medicine, and the Surviving Sepsis Campaign, all silent when it comes to the SOFA score, which I think is quite telling.
And this also, my other thought on this too is that, going back to that, is that, you know, this also helps support for our coding professionals out there, you know, that these are what we need to see in the record, obviously, to code a diagnosis as well. Okay, so let's talk about state policy approaches to sepsis prevention and early recognition. So there's 4 that are published by the CDC. I've got a PDF URL there where you can go and download this. There are 2 states, the state of Illinois and the state of New York, who actually have laws in place that help define sepsis. The other states, Ohio and Wisconsin, have initiatives, and these are you could see their name, Gabby, Rory, and Katie on 3 of them. These came about because of occurrences in those states where sepsis was not identified early, it was not diagnosed, and it was not treated early in these people's course of their illness, and they ended up, all of these folks ended up dying, and I think all 3 of them were young. I know at least for the Rory regulation, they were all, he was like a 9-year-old boy, I believe. The state of New York really, I think, has the strongest regulation in that they have a law that says SEP2 is sepsis, and they have really made inroads into pushing back to payers who are trying to use the SEP3 criteria. And so we do a lot of work for some hospitals in New York, and we've had at PayerWatch great success in appealing sepsis denials because of this regulation in the state. and because we have the opportunity to take these cases to external review, which is outside the payer's appeal process. Okay, so once we've done the 2 internal appeals to the payer, we can take them to external review, and we've had great success there. So I want you to think about, what's going on in your state, and whether there's some advocacy that you can do to help, put some policies in place that help recognize SEP2 as a valid way to diagnose sepsis. So these collaborative efforts alone of these 4 have led to a 16% decrease in mortality associated sepsis since 2013. So it's not all about do we get paid for it or not. It's also about making sure that our patients are being, our people in our community are being recognized with early onset of sepsis, and they're being treated, and so the quality of care that we're providing is of paramount importance. Here are some other state mandated protocol-wise sepsis care. So here are some other articles that I would just encourage you to take a look at that talks about, for example, a roadmap for successful state sepsis regulations, lessons learned from New York. So if that's something that you're interested in advocating for in your state, here are some good articles for you to access in order for you to take up that battle. And then this comes from one of the articles that I just cited, that it shows the states that have regulatory programs, New York and Illinois. Ones that have voluntary programs are the ones in green. The ones in white have no state level programs. Okay, so you can kind of see how you're doing in your state. Here are some references to the various sepsis diagnoses. And I'm going to let Dr. Kendall Smith talk a little bit about ALJ hearings and experience with sepsis. And I'm going to encourage you to put your questions in the questions box. It doesn't look like we're probably going to have time to get to maybe more than 1 or 2, but go ahead and put them in there because we will do our best to answer them after the presentation. So go ahead, Dr. Smith.
Yeah, I'll be brief with the issue of ALJ hearings. And, ALJ hearings are a matter of personal experience and personal opinion as to how to prevail. I want to leave some time for Dr. Ossman, Denise, and myself to answer questions while everybody's here. The biggest issue we're seeing with ALJ hearings currently are issues that I think Dr. Ossman talked on earlier, where you've got an infection with we'll see evidence of organ dysfunction, or the argument from the auditor is that the findings are to be expected with a localized source of infection, i.e. they may argue that a UTI is expected to have acute kidney injury associated with it, that pneumonia, it will have hypoxia and respiratory failure as a localized consequence of that infection. And the goal in the ALJ hearings is one, to educate the judge as to how this is not expected. Not every case of pneumonia presents with significant hypoxia or an AA gradient. Being able to calculate things objectively like an AA gradient and explain it to the judge often goes a long way in getting these cases overturned, reminding the judge that sepsis 2 is, at least under the terms of Medicare, what's being looked at. We've had some auditors try to creep in and start to throw in things like SOFA scores. So there's a need to jump on those arguments early and deliberately. And I think finally, Dr. Ossman had pointed out with the peer-to-peers or the letters, to the extent that you can point out that this was not a typical pneumonia, look at the ALOS for DRG for pneumonia, maybe 3 or 4 days, show that the patient was there 8 days. Typically pneumonia treated, community-acquired pneumonia with simple azithromycin or ceftriaxone, the patient's on a much broader spectrum antibiotic. They're getting respiratory therapy or nursing care at a higher intensity than you would normally expect. So if you can show a significant expenditure of resources by the hospital staff that goes well beyond what you would normally expect, that often has weight with the ALJs, as does any subjective language that you can point to, such as toxic appearing, or other language associated with that patient to paint a picture of what was going on at the bedside. And I'll rest at that point. I'd like to open up for some questions with the remaining few minutes that we have here.
Yeah, we've got a few minutes. I see a couple of good questions that I think a lot of people probably would like to hear the answer to. So one is, are you finding that documentation needs to include a causal relationship between the organ dysfunction and sepsis? Or are you successful in appealing or doing a peer-to-peer with denials where just the two conditions are present? That's a really good question.
And a lot of it is insurer dependent. Some of it is even peer-to-peer doc dependent. And I think the answer is probably what's expected, and that is that if that causal relationship is documented, our job is a lot easier. When it's not documented, though, we've had successes very similar, as Dr. Smith has said, is if you can really paint that picture and show that that patient meets their criteria with that organ dysfunction, is often we're often able to overturn it. But a lot of it is just getting that narrative, getting that full picture of what was needed. I wouldn't let the lack of that clear documentation keep you from moving forward. That said, when we send our queries for severe sepsis, we are including in that those choices is that severe sepsis with organ dysfunction as evidenced by, so that when our providers are answering the questions, we're getting that support. So we're not having to send multiple queries for the same thing.
And we'll often go through the charts where a SOFA score wasn't calculated and calculate and make that calculation, highlight the record as to where the information was found, and put that in front of the insured. And we've had good success in doing that. So it may not have been thought of at the time, but I think retrospectively, if you have nothing else and you can show they had a SOFA score of 3 or 4, by all means, connect the dots and show them how you did accomplish that.
I agree. Okay, one more, and then we'll wrap it up. The next question was, do your contracts include peer-to-peer escalation for DRG downgrade? One of our issues is that peer-to-peer option is only available for medical necessity appeals, but not for DRG downgrade.
Yeah, that's a good question, and we have had success, particularly with Optum, in that there wasn't initially a pathway for a peer-to-peer, but through their medical director, we've been successful at getting peer-to-peer scheduled for different cases, and really we're just making use of that peer-to-peer model much more often. It gives us, even if we lose, it at least gives us insight to which cases we really want to push back on as far as knowing why we've been unsuccessful. And that kind of ties into the previous question. There have been a couple peer-to-peers that I've let our staff know, I think we're going to lose this one because clinically it wasn't super clear. But they had these kind of arbitrary 2 SOFA points that we found, and they were very much live by the sword and die by the sword. So kind of moving forward is helpful, even if that avenue isn't a.
Oh, we lost your sound.
Oh, sorry. We've been doing that through tenacity. We just keep asking, and we've been successful at getting this peer-to-peer.
And I think there's a value both in ALJs and peer-to-peers of keeping track of the outcomes from the other side, because you'll see a broad spectrum of responses. And with respect to peer-to-peers, we've seen, or at least I've heard of medical directors that denied everything, actually hospital complaining, having the medical director removed from the market, and then the medical director popping up in another market and creating havoc again. So, keeping track of your outcomes with peer-to-peers, who you discussed this with, was it overturned? Was it upheld? Was there, a really contentious discussion that it was going nowhere? And making a predictive model as to how feel that this should have gone, and should it have been reasonably overturned, you'll start to pick out the physician advisors on the other end, the medical directors on the other end, that you may want to engage through your managed care department and ask that they engage with other hospital systems for the sake of the relationship.
All right. Well, that wraps it up for today. Thank you, Dr. Ossman, so much for being our invited guest today. Great hearing everything that you have to say about what's going on at your shop. And Dr. Smith, thank you so much for your insights and sharing of your experiences as well. Make sure you sign up for the next 2 webinars. You can do that at www.PayerWatch.com. And if you have any questions, you can certainly email me at dwilson@intersecthealthcare.com, which was our prior name for PayerWatch, and Dr. Kendall Smith is ksmith@intersecthealthcare.com. Thanks, everyone. Have a great day. We'll see you in a week.
Thanks, Paul.
Oh, thanks for the opportunity. It's a pleasure.
Thank you, Denise. Bye-bye.